I just wanted to thank the organizers for inviting me to speak today. I'm actually going to be focusing my talk in the interest of time and really trying to provide more of a comprehensive approach on really just multiple myeloma today, but I believe that there's going to be a lot of associations that you could probably make through the various different heme malignancies in my talk today. And so with that, we'll get started. The big three main topics that I'm going to be covering today is going to be on smoldering myeloma, a new frontier of therapy, presenting some interesting data on the Aquila trial, as well as going into our use of minimal residual disease assays in the multiple myeloma field. I'm going to go through a lightning round of 4 key pivotal trials that are doing just that, integrating MRD into the therapeutic landscape and also looking at how they're utilizing them as endpoints. And then finally, I'd like to leave you with a few sort of future insights in how we are using some novel agents such as bispecifics and even trispecifics in the myeloma field. And so with that, just to kind of quickly kick off a brief primer, as we all know, multiple myeloma is a cancer of the plasma cell. Under normal circumstances, these plasma cells, they make monoclonal antibodies as part of our immune system to help coordinate immunological attacks. And so when a plasma cell turns malignant, we know that these plasma cells will then go ahead and generate monoclonal antibody protein. Multiple myeloma, as we know, is the second most common hematologic malignancy, but it is the most common hematologic malignancy among African Americans, accounting for about 30,000 cases per year. If we look back and look at its prevalence over the last few decades, we know that the prevalence of myelomas is increasing, really mainly because our therapeutics are getting better and better, and so patients are living longer, and they're living longer with their disease, turning it more into a chronic malignancy. When patients become symptomatic, they can often experience renal compromise, neuropathy. Their immune system can have dysfunction, and our patients are often plagued with infections. And then oftentimes patients can have different electrolyte abnormalities, decreased blood counts, and can also be plagued by bone pain lytic lesions, including being at risk for pathologic fractures. And so one thing to really kind of note is that multiple myeloma is always preceded by a precancer disease state defined as MGUS or smoldering myeloma. Here we have the 2014 International Myeloma Working Group criteria for multiple myeloma and its associated plasma cell disorders. And what you'll find here is that in the 2014 criteria, multiple myeloma is still defined by the symptomatic CRAB criteria that we know about, which is hypercalcemia, renal insufficiency, anemia, and bone lesions. But in 2014, what researchers had done was also taken more of a broader look and broadened the criteria to include asymptomatic patients, but have high disease burden markers. And they define those as having myeloma-defining events. And they were noted to be patients that had 60% or more clonal plasma cells in their bone marrow, or they could have involved light chains of over 100 or 2 or more focal early bone lesions on MRI. In contrast, MGUS and smoldering patients remain asymptomatic, and the real distinction between MGUS and smoldering has to do with the disease burden. You'll see here with smoldering, patients need to have at least M-spike of 3 grams per deciliter or more, or they can have urine M-spike of 500 milligrams over a 24-hour period, or they can have bone marrow plasma cells between 10 to 60%. In contrast, MGUS patients have to have at least or less than 3 grams per deciliter of M-spike, and then they have to meet criteria where their bone marrow plasma cells are less than 10%. It's important to know that patients that have MGUS and smoldering will not always go on to progressing to having multiple myeloma, but what we do know is that the risk of progression for MGUS is around 0.5% to 1% per year. And for smoldering, it's higher, based really solely on the fact that it's higher disease burden. It's around 10% per year for the first 5 years, and then decreases thereafter. And so the clinical dogma for how we manage MGUS and smoldering patients has really just been observation, and really still is really observation. But over the last 15 to 20 years, what we've recognized is that we can do a better job of prognosticating who's really at risk for developing multiple myeloma in these precursor disease states. So we've come up with a bunch of different risk models. What's important to realize also is that high-risk smoldering myeloma really represents the group of patients that has the most potential to transform into multiple myeloma. And from diagnosis, they average around a 75% risk of progressing in the next 5 years. And so with that, over the last couple of years, there's been a real approach to trying to get high-risk smoldering patients to early interventional clinical trials, because this is the group of patients that may have the riskiest risk of progression. And so with that, we have the Aquila trial, which is one of the studies that was presented at ASH of 2024 last year and then subsequently published. This is a study that was enrolling smoldering myeloma patients and randomizing them to daratumumab monotherapy versus active monitoring therapy. Important to note a couple of things here for eligibility criteria was that this trial included a number of different risk factors and didn't necessarily focus only on one particular smoldering risk model. These days in the field, we use a risk model called the 22-20 model to really sort of understand who's the high-risk patients, but you'll notice that this trial does not necessarily stick to just that model. The other thing to also note is that the daratumumab monotherapy arm was really a fixed duration of therapy, so it's not that patients were continuously getting therapy for long periods of time, which is really the approach that we take for active multiple myeloma. The primary endpoint for this trial was essentially progression. And so what you'll notice here in terms of the baseline characteristics is on the right, again, we see that we have a number of different smoldering patients enrolled onto the study, not just limited to high-risk smoldering only, which I think is sort of a criticism of this study. Although the majority of the patients were high risk, you'll see at least by the Mayo 2018 criteria, we still have low risk and intermediate risk patients that were indeed enrolled onto the study. The bottom line, nevertheless, is that what investigators showed was that DARA really reduced the risk of progression or death by 51% compared to the active monitoring arm. And it wasn't just myeloma-defining events that they improved or biochemical progression in these smoldering patients. It was actually symptomatic CRAB criteria. You'll see in the DARA monotherapy arm around 6.2%, really reduced compared to 17.3% in just the active monitoring arm. So essentially, early intervention is warding off clinical organ damage in some of these smoldering patients. With respect to OS, we find that the early intervention with fixed duration of daratumumab extended overall survival compared to active monitoring, which is really an important highlight of this particular study. And in the patients that actually received treatment in the daratumumab arm, it's noted that the majority of deaths were due to disease progression and not because of AE events. In terms of the question of whether or not early intervention for this particular group somehow impacted later lines of therapy, investigators looked at PFS too, and they noted that DARA improved PFS on the first line of treatment for myeloma versus active monitoring, and did not really impair later treatment. But it should be noted that most of the patients went on to getting RVD after they subsequently progressed. And only about a quarter to a third of patients actually got daratumumab or an anti-CD38 subsequently. This is very different than what we do in practice today, because a lot of our patients that are newly diagnosed will go ahead and get that anti-CD38 incorporated into the regimen. So not necessarily applicable to what we're doing today in actual clinical practice. So the key takeaways for this study was that DARA monotherapy improved PFS, OS, and PFS2, especially in the high-risk smoldering group without excessive toxicities. It's important to note that just this year, the FDA ODAC had a vote on this in favor of deciding daratumumab be recommended for high-risk smoldering treatment, but a final decision will happen later on this year of whether or not a label change will occur with respect to daratumumab. And so we'll see later on whether or not this will really be practice changing. To switch gears a little bit, I'm going to talk a little bit about how we do our traditional diagnostic workup for myeloma patients and how we monitor our patients. As many of you are aware, we really use traditional markers still in the clinic to see who's at risk for having myeloma, and that includes serum chemistries and urine chemistries, including SPEPs and UPEPs, as well as doing our traditional bone marrow biopsy assessments, which will look at CD138 immunohistochemistry staining. Patients will often go through mutation analysis by FISH and cytogenetics, and then also get scans to evaluate their disease. But in 2025, the development of minimal residual disease assays are really enabling us to detect lower limits of disease. And this is really important when it comes to patients that we are monitoring after treatment in particular. So briefly, what is minimal residual disease testing? It refers to the detection of remaining cancer cells or disease markers, which can be in the form of protein or cfDNA that really represents ongoing cancer cells after treatment. And so this is critically important right now in our field because the therapeutic landscape of myeloma has really changed. In our induction regimens, we're essentially seeing in the clinic patients that have overall response rates of 100%, and some really have deep responses, averaging around 60 to 70% with some of our quadruplet-based regimens. And so with that, there's a critical need for us to detect the disease beyond just our traditional measurements, which becomes really important as we start to frame out how we're potentially curing our patients. And the second most critical reason why assessing minimal residual disease testing is important because it's really associated with clinical benefit, both PFS and OS benefit. This is a pooled analysis from some of the more recent induction regimen trials, and what we see is that patients not only achieving an MRD negative response, but sustaining it for long periods of time is tied as a surrogate marker for a PFS and OS benefit. And so with that, last year in 2024, the FDA ODAC voted in a unanimous vote to recommend the use of MRD as an accelerated primary endpoint in multiple myeloma clinical trials. And as we start to think about how we really are approaching our patients and maybe even discussing a functional cure for them, The first step in that ladder is really integrating these assays that detect the disease at lower thresholds, and integrating them into not only the clinical trial for endpoints, but integrating them into possible treatment algorithms. And so with that, there's a number of different trials that came to light in the last year or so, essentially looking at minimal residual disease that I wanted to point out and highlight. The first is the MIDAS trial, which is termed Minimal Residual Disease Strategy Study Design for Transplant-Eligible Myeloma Patients. This was born out of the French Myeloma Working Group. And essentially what they did with this study design was they gave transplant-eligible patients 6 cycles of a quadruplet-based therapy. In this case, it was ESA-KRD. And then after that, depending on their risk and their MRD status of 10 to the minus 5, they further randomized patients. So patients that had standard risk were then randomized to either receiving just consolidation or further chemotherapy versus transplant plus consolidation. High-risk patients that were MRD positive then went on to either getting 1 transplant or randomized to 2 potential transplants. And so what we realize in this study design is that they're really looking at trying to take an MRD response-adapted approach. What they found with this study, and was initially sort of published and then presented as early or as late as ASCO of this year, was that essentially for patients achieving an MRD negative response of 10 to the minus 5, there was really no difference whether or not patients were then going on and getting transplant versus chemo when you looked at response rates of 10 to the minus 6. And so while longer follow-up is still needed with this particular design, it's really kind of interesting to see if patients reach a certain depth of response, whether or not transplant is actually needed or not. So we'll look forward to seeing how this plays out in the future. The next study is the advanced study, which is the DARE KRD study versus KRD, essentially looking at a quadruplet versus a triplet. This was in newly diagnosed patients that were both transplant ineligible and transplant eligible. And what's unique about this study design that you'll see is that the transplant eligible patients got 4 cycles of induction therapy. They went on to getting stem cell harvest or collection, and then automatically got another 4 cycles of therapy, depending on which assignment you had. What's important to note here is the decision on transplant occurred after the total 8 cycles of induction therapy. And so for those patients that were still MRD positive, 10 to the minus 5, that's when they made the decision whether or not to proceed with transplant or not. We saw updated results from this, and this is really still very early. The primary endpoint for this trial was MRD status of 10 to the minus 5, and this was in favor of the quadruplet regimen of DARE KRD, 59% compared to 33%. But we'll see how this response-adapted approach plays out in the future with respect to other clinical endpoints. The next study to go over is the Cepheus study, which was also published last year. But this study is the equivalent of the Perseus study, but for transplant ineligible patients that were enrolled onto study. Important to note, these were transplant ineligible patients, but they were fit patients. So in terms of frailty score, you had to be 0 or 1 or performance status of 0 to 2 to be eligible for this study. Again, we see that the primary endpoint of this study is looking at MRD negativity. So again, incorporating that FDA guidance. While it was published last year, we had updated results at ASH of 2024, essentially looking at the quadruplet arm, which showed that adding daratumumab to the RVD backbone led to a 50% increase in MRD negativity rate, which actually translated into a PFS benefit with reduction around 43% in the risk of disease progression or death. And lastly, the last trial I wanted to highlight that incorporated minimal residual disease testing was the ORIGA trial, which is really an interesting take. This is the trial that was looking at newly diagnosed patients, but really looking to see how MRD assessment can be incorporated in the maintenance setting. So in order to be enrolled onto the study, patients had to have had a transplant. They had to be MRD positive 10 to the minus 5 before enrollment, and you could not have any prior anti-CD38. So they had to be daratumumab naive or isatuximab naive, which is, again, a little bit not applicable to what we see in clinical practice. Most of our patients are getting quadruplet-based therapies. Nevertheless, once patients were enrolled onto trial, they were randomized to either getting dara-rev maintenance or rev maintenance alone. And the primary endpoint of this study was looking at MRD conversion after 12 cycles of therapy to see if you go from being positive to MRD negative. The study was published last year, I believe around in November, in favor of the dara-rev group, which had higher conversions. But in ASH of 2024, we saw some more updated cytogenetic analysis. And what's important to note is that the patients that had high-risk cytogenetics actually also benefited from dara-rev maintenance. And at least in patients that had gain or amplification of 1q21, which is one of our high-risk subgroups, there seemed to be a PFS benefit here. So it's, again, whether or not this study is really sort of translatable in the era of where we're using a lot of daratumumab up front, it's hard to necessarily say. But at this point, it's sort of interesting to see how utilizing this MRD endpoint assay is really becoming more integrated into our clinical trials. And key takeaways from the last couple of pivotal trials was that quadruplets continue to demonstrate superior clinical outcomes, not only in transplant-eligible patients, but transplant-ineligible patients in the induction regimen setting. And we're really starting to see how these MRD assessments are being integrated into the clinical trial design. And I think as we start to see more of those efforts, we'll start to see, again, even some of these clinical trial designs incorporating a response-adapted approach, similar to what we saw with the MIDAS and ADVANCE trial, where MRD responses are being integrated into treatment algorithms, not just endpoints. So moving on to the last section of my talk today, I wanted to talk to you briefly about some of our novel therapeutics and what we're seeing in the clinic today in terms of clinical trials. So as many of you are aware of, in multiple myeloma, we have a number of different T-cell engaging therapies that are approved already and out on the market for commercial use. I've listed a few of them here on the slide, both bispecific antibodies and CAR T-cell therapies. And what you'll notice is that the current FDA-approved therapeutics are really primarily targeting BCMA, which is an antigen that is on the myeloma surface. And so beyond BCMA, we're starting to look at what other potential targets are out there for therapeutic use using T-cell engaging platforms such as CAR T-cells and bispecifics. You'll notice that talquetamab is a bispecific that's approved, and it's targeting GPRC5D, which is a different myeloma antigen target. But what do we have even beyond just BCMA and GPRC5D? So we also have a different target called FCRH5. And so with ASH of last year, we saw some updated results from a phase 1 study looking at a drug called cevostamab, which is a bispecific antibody targeting FCRH5. This was conducted in patients that were heavily pretreated, and allowed in for the inclusion criteria were patients that had had prior CAR T cells, and BCMA bispecifics as well were allowed on this study. And so in terms of responses, what we saw was that that in patients overall was a 44.3% response rate. In patients without prior BCMA therapy, it was as high as 60%, and then down to 32% with patients that had had prior BCMA. The median time to first response was around 1.4 months. It's important to note that the responses deepened over time, which is similar to what we see with a lot of the bispecifics in the clinical setting these days. What's interesting about this trial design was that, again, it was a fixed duration of treatment. So patients essentially got around 12 months of treatment, and then they automatically stopped. But what this slide is highlighting is that even though patients stopped treatment after a fixed duration, those patients that had deep responses continued to have a very durable response beyond their treatment period. And so when we talk about bispecifics in the clinic, these types of trial designs are going to be more important to see how we can really incorporate fixed durations of treatment strategies rather than just ongoing giving treatment to patients that may not necessarily need them beyond. The next compound that I wanted to highlight was J&J 5322. It's a trispecific, so first in class. It's targeting both BCMA and GPRC5D. Really some sort of exciting results. This was a phase 1 study that we saw some results on that was presented at ASCO and EHA. In this setting, these patients were highly pre-treated again, and again, they went through different dosing cohorts. Important to note a couple of things with the adverse events. We saw the same typical adverse events that we see with respect to teclistamab and talquetamab, which are hypogammaglobulinemia, but with talquetamab, which is a GPRC5D bispecific that's approved, patients can oftentimes experience a lot of nail, skin, and taste changes, which can be really cumbersome for treating patients in the clinic. A lot of our patients were getting weight loss, and while it's a highly efficacious drug, what's interesting about this particular agent is that, yes, we still see that on-target side effect of taste, nail, and skin changes, but it's really dampened compared to what we see to its counterpart, which is talquetamab. The response rates in overall were around 55%. In BCMA and GPRC5D naive patients, it was around 100%. It should be noted that patients that were prior BCMA and GPRC5D exposed were allowed to be enrolled onto this study, not necessarily refractory to those agents, but we see that this is really some promising overall response rates and maybe a little bit better tolerated compared to its bispecific counterparts. So key takeaways, from this set of slides is that we see some really promising antigen targets that I think we'll see in the future that will go on to developing both CAR T-cell and T-cell engaging therapies beyond just BCMA. And so with that, some final thoughts on where we are with multiple myeloma. We see treatment paradigms are evolving in high-risk smoldering from watchful waiting to proactive risk-based therapies. Reaching and sustaining MRD negativity is associated with prolonged PFS and OS and can be utilized as a surrogate endpoint in myeloma clinical trials and may be in the future actually incorporated into certain treatment algorithms down the line. Therapeutic targets such as GPRC5D and FCRH5 are promising potential targets that we can utilize for T-cell engaging therapies in the future, hopefully broadening our therapeutic landscape. Thank you.
We have a moment or two for any questions, if If you have any questions, please raise your hand and I'll run over with this mic. Well, thank you very much. And for